Hi there, my name is Mike Sullivan. I'm the Program Director of Valor Medical Services. I'd like to welcome you to this presentation from our series of continuing education for pre-hospital providers. Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Alrighty, now that we've got all that legal stuff out of the way, before we get started, let's talk about coffee for a second. If you're looking for a great cup of coffee, you probably want to check out coffeebrandcoffee.com. They're an online retailer, American owned and operated. They have a wide variety of coffees, teas, hot cocos, all sorts of different flavors. They've got all sorts of organic teas. You can get coffee in bean form, ground form, K-cups, whatever your heart desires. I've had several of the different blends and several of the different flavors. Absolutely fantastic. And because they are an American-owned small business, they don't have a big warehouse, so they don't have a big supermarket sales business. They roast it, they bag it, they ship it to you. It'll pretty much be some of the freshest stuff you'll ever get. Definitely highly recommend them. And they've got a promo code out for us now. If you use promo code VALOR SDS, you get a 5% discount off any order. So you can save a little money, try some fresh coffee, see what you like. They've always got different flavors coming through on their website. Some are permanent, some are limited time only. And if you look right there in the picture, you can see they've even got, yes, double caffeinated. Definitely a winner around this office. Alrighty, now let's get to class. Hey there, my name is Mike Sullivan and I'm one of the instructors at Valor Medical Services. In today's presentation, we'll be discussing thoracic trauma. Now, as we break into this program, we'll look at a few of our core objectives. We're going to identify major structures within the thoracic cavity. We're going to analyze and classify chest injuries based on the structures involved and how we can manage those. We'll explain the signs and significance of flail segments or flail chest wall. We're going to evaluate thoracic injuries and determine appropriate care and pre-hospital management. We'll distinguish between the various types of pneumothorax or pneumothoraces. We'll distinguish between hemothorax, pneumothorax, and hemopneumothorax. And we're going to discuss and explain the management of cardiac-related injuries. Now, as we prepared this program, one thing that sort of stuck in our mind was a few fast facts. Thoracic trauma caused over 700,000 ED visits and roughly 18,000 deaths each year in the U.S. So not only is there a high frequency, but there's also a high degree of acuity with these calls. We go back to 2015 statistics, thoracic trauma made up over 20% of the reported trauma incidents and was a contributing injury in over 25% of trauma deaths. So that again goes to show, yes, we see it. Yes, we see it a lot. And yes, it is something that can be extremely consequential for the patient. Therefore, we need to be able to treat it as well as we possibly can. Now, as we look at the anatomy of the thoracic cavity, the thorax is made up of a bony cage that encircles the cavity on the anterior and posterior sides. Overall, we have 12 sets of ribs combined with dense muscle groups that provide protection to the vital organs contained in this portion of the body. We often don't think of the muscle groups, but they actually provide a great deal of padding and protection to the rib cage, as well as structural support for the ribs. The superior border of the thorax is actually the thoracic inlet at the base of the neck, while the inferior border is the diaphragm. This actually forms an airtight container. In the average human, without an injury, you think the only way for air to move in or out of the thoracic cavity at all would be by way of the airway itself. Thus, when we take a breath, we pull air in through the airway. When we exhale, air goes out through the airway. That's the way it's designed to work. Now, we'll look at some of the other anatomy. We have the heart within the thoracic cavity. In the pericardial sac, we have the lungs, which are encircled in the parietal pleura and the visceral pleura. We also have the lower portion of the airway, and multiple great vessels running throughout the thoracic cavity. A couple to think of are the aorta, which is the primary discharge from the heart going out to the rest of the body, or the superior and inferior vena cava, which again is the primary return from the rest of the body to the heart. Damage to any of these vessels, a patient can bleed out within minutes, and there's very little at that point that we could do. Also, in the posterior aspect of the thoracic cavity, there's a significant section of the spinal column. Now, as we go through, let's look at some of the common thoracic injuries. One of the most common injuries we see is fractures. Now, these can be rib or sternal fractures, clavicle fractures or collarbone area, or potentially a flail segment or a flail chest wall area. Now, fractures, for the most part, a simple fracture within the thoracic cavity does not affect the cardiovascular system, barring the fact that either bone fragments or a jagged piece of bone ends up hitting something or damaging a vessel. Again, the most part, they're not going to have a direct effect. They can, however, have a major indirect effect. If we take a patient with 1 or 2 broken ribs, they are having severe pain. Well, this severe pain is going to stop them from inhaling or exhaling deeply. It's going to greatly decrease their tidal volume. Now, if we take the fact that the average adult has a tidal volume of about 350 ml effective, then we know if we lose a significant amount of that tidal volume, what happens? Well, hypoxemia or low oxygen levels, or hypercapnia. Simply managing the pain, can actually assist the patient maintaining an adequate tidal volume and improve their breathing. A second issue is if there's damaged thoracic pressure. If there's too high pressure within the thoracic cavity due to a simple injury, we can have poor venous return. Simply stated, it's harder for blood to flow back from the body into the thoracic cavity if the pressure is too high. If the blood cannot flow adequately into the thoracic cavity through the superior and inferior vena cava, it's going to back up, and that can decrease the preload. Decreasing the preload to the heart, of course, will decrease the heart's output. So again, although they may not directly affect the cardiovascular system, there can be multiple indirect effects that come into play as a result. Now, going beyond simple fractures, let's look at a flail chest. Now, by definition in PHTLS, a flail chest is defined as 2 or more adjacent ribs broken in 2 or more places. Now, this can be associated with a 50% mortality rate, as well as higher mortality rates in the elderly. It's evidenced by a free-floating segment that will move paradoxically as compared to the rest of the chest wall. This can cause a loss of up to 1/3 of the effective tidal volume. So let's look at why we're having paradoxical movement. Well, when the normal patient takes a deep inhalation or a deep breath in, the diaphragm moves down, the ribs move outward, and that creates a vacuum. This vacuum tends to suck air in through the airway. That's the only inlet to the thoracic cavity. Well, that vacuum, if we have a thoracic segment or a flail segment in the thoracic cavity that's free-floating, when the ribs go to move out, that vacuum will actually pull the free-floating segment inward, moving opposite to what the rest of the chest wall is. The converse of this is when a patient exhales. On exhalation, the diaphragm will move up and the ribs will move inward. This creates an increase in pressure in the thoracic cavity that pushes air out through that airway. Well, if the increase in pressure in the thoracic cavity that's designed to push the air out will actually cause the flail segment to bulge, again moving the opposite direction of the rest of the chest wall. Not only is this incredibly painful for the patient, but it also again causes a loss of tidal volume because everything's not working together. So when we look at a flail segment, what do we need to do? Well, the biggest thing at that point is trying to splint the flail segment as easily as we can, either with a bulky dressing, sometimes just putting the patient's arm along it, something to limit its movement, which limits the loss of tidal volume and also helps limit the pain. Patients with a significant flail segment, say 4 or 5 ribs that are adjacent, broken in 2 or more places, may develop several issues with long-term pulmonary function, including ARDS or loss of elasticity in the chest cavity as a result of being unable to adequately exhale, and thus, again, long-term consequences, lung damage, scar tissue in the lungs, those type of things. So again, yes, it's an initial problem acutely at time of onset, but it also can present with chronic problems down the line. Going onwards and upwards, let's look at some of the airway or lung issues. Now, one type of lung issue would be a hemothorax, or we could have what's called a pneumothorax, and those can be open pneumothorax, closed pneumothorax, spontaneous pneumothorax, tension, and each one of those would indicate a different thing. In an open pneumo, we would have air exchange from the outside through the chest wall into the lung space. If we had closed pneumothorax, it may be that air is escaping internally from the lungs themselves into the parietal pleura and visceral pleura, but it's not open to the outside, not open to the exterior. A spontaneous pneumothorax would be when we have a patient who experiences a pneumothorax in an atraumatic or non-traumatic setting. For example, a patient with a long history of emphysema, or in some cases some types of congenital injuries such as Marfan syndrome. The patient has a sudden coughing fit, and just by coughing so hard, they manage to tear one of their lungs. Thus, it would be a closed issue, closed pneumothorax, and again, it would present in an atraumatic setting. So it would be the asthma attack patient who had a sudden coughing fit, or the emphysema patient who had a sudden coughing fit and was incredibly short of breath, and all of a sudden you listen, you're not hearing breath sounds on one side. They deny any trauma or injury. There's no bruising, no nothing that you can see from the outside. However, could they potentially have a pneumothorax? Very possibly. Lastly, we deal with a tension pneumothorax. Now, whether it's a closed traumatic or a closed spontaneous pneumothorax, or even some types of open pneumos, a tension pneumothorax develops when one of the sides has collapsed and has leaked so much air around that lung that it is actually creating excessive pressures in the thoracic cavity. This air pressure in the thoracic cavity can't vent, and therefore it may tend to squeeze the heart, again limiting preload, limiting the heart expansion, limiting the ability of the heart to pump adequately. It can also begin affecting the opposite side. That is no injury, no nothing wrong with it. However, all that air is now not allowing that lung to expand, and again developing tension. In this case, it's when we start to see the tracheal shift, and we'll talk a little bit further about the types of pneumos here in a minute. A tracheal tear. We look at where the trachea comes down, where the airway comes in. If something happens and damages that, we can have air escaping from there, again, into the thoracic cavity, into the area around the lungs, and again, taking up space that would otherwise be used for the lungs to inflate or the heart to expand, and we now have that combined with sub-Q emphysema, where we start to see almost air bubbles popping up under the skin and the subcutaneous fat. Now all of a sudden we're actually starting to see like a rough textured surface beginning to pop up on the patient's chest wall. Again, this could be due to trauma, it could be due to various things. Lastly, a pulmonary contusion. Now, many pulmonary contusions may not develop immediate signs and symptoms. However, like any part of the body, a significant contusion can lead to swelling and fluid building up in the area. Well, a pulmonary contusion, if we have swelling of the lungs and fluid building up in that area, can affect and effectively damage gas exchange. So we could have a problem there. Again, difficulty oxygenating and off-gassing CO2. So we could end up with hypercapnia or hypoxia as a result of those. Now, let's look at these lung injuries a little bit more. In the first figure here, you see healthy lungs. The lungs themselves are contained within the visceral pleura and the parietal pleura. However, they're able to expand freely all the way out to the chest wall and take up that whole area of the cavity. In the second one across, we see a pneumothorax. Pneumo would apply to air, and what's happening in this one is air is escaping from the right lung, and that air is now taking up space within the visceral and parietal pleura and preventing the lung from reaching its full air capacity. This would actually eliminate breathing volume and can also, again, squeeze the other lung eventually, the more air that escapes. The third photo over shows a hemothorax. Now, a hemothorax would apply to blood. So in this case, instead of an air taking up room in the space, we have blood taking up room within the visceral and parietal pleura, and that blood is actually preventing the lung from expanding adequately. Again, either a pneumo or a hemothorax both cause us tidal volume loss and again cause us loss of gas exchange. The last figure over, number 4, is a hemopneumothorax. In this case, we've got both air escaping and blood in the pleural space. As you can see, again, it's compromising the lung volume for the lung on the patient's side there, so we're having a difficult problem. Any of these, again, loss of tidal volume, difficulty breathing, increased respiratory rates because they're having to breathe a lot faster because they can't get the volume of air they need per breath. Now, earlier I mentioned we'd go a little bit further in deep into open and closed pneumothoraces. Now, if we look here, on the top figure, the top diagram, we have a normal lung on the left side, a collapsed lung on the right-hand side. This is a closed pneumothorax, as the air that's escaping into the visceral and parietal pleura is actually leaking out from the lung. This could be a spontaneous or a traumatic pneumothorax. We don't know necessarily what could have possibly caused it, but in that it originated on its own interior to the patient, there's no vent to the outside. That closed pneumothorax is allowing the air to build up in the chest cavity, in the thoracic cavity itself, as well as around that lung. The second figure down is an open pneumothorax. Now, in the open pneumothorax, this would more likely be traumatic. There's a hole, whether it be from a bullet or a knife or an ice pick or whatever has dug into the patient's chest. It's not only created a wound in the chest, it's also created a wound in the lung itself. Air, in this case, is circulating freely from the inside to the outside. Now, given the fact that this hole is actually allowing air to circulate, when the patient goes to inhale, it's actually not only going to pull air in through the airway as we're designed, it will allow air to move freely through that hole into the chest cavity, but not to the lung itself, and thus accumulate in the space around the lung. As the patient exhales, we'll see air move out through that side hole. Now, the air moving out through the side hole typically will have bubbling blood or something bubbly with it. There'll be an indication of some sort that there's air exchange going on there. We may see blood get sucked in when the patient exhales and bubbles when they, blood gets sucked in when they inhale and bubbles get when they exhale. So at that point, we want to continue to let the air come out. However, we want to stop air from going in. This is what's called the stereotypical sucking chest wound. Now, on the last slide, we have a tension pneumothorax. In this case, again, the air that's accumulated in the pleural cavity, whether it be from air moving in and out through the chest wall or air just escaping from the lung and accumulating in the chest cavity, regardless of how it happens, as you can see, there's more and more tension, and that will cause our classic tension pneumothorax, where we're losing significant amounts of thoracic volume, as well as the significant amounts of preload and heart volume. So to manage an open pneumothorax, well, we see our standard presentation of our sucking chest wound, and as we start addressing our sucking chest wound, the quickest way to do it, again, we have an open wound to the exterior, bubbling blood around it, noted in relation to the respiratory cycle. We should see this in our primary survey, and if we do, we can seal it with a gloved hand or a gloved finger immediately, stopping that air from going in and out through that hole. At the same time, we need to begin looking at a way to seal it. Now, in the picture shown there, it's sealed with just a plastic wrap or a piece of plastic from some item that we used on the truck, and it's taped on 3 sides to allow a little bit of air escape. Our goal here is that when a patient inhales, the plastic sucks flat to the wound, doesn't allow any air to go in. When the patient exhales, any air that wants to come out that way can actually escape and get out through our flutter wound. Now, that's an improvised seal there. There's actually many commercial seals available out on the market. In this picture, we've got, on the far left, the Asherman chest seal, which again is a round plastic seal. It peels off, it sticks very well to the patient's chest wall. It's got a little one-way flutter valve in the center of it, so air can come out, but air doesn't get sucked back in. The second picture is, I believe, a hyphen chest seal. It's marketed by North American Rescue. Very similar to the first one, except instead of having a flutter valve on it, you'll note that the little seal up the top left corner and the bottom left corner have an area with no adhesive. So that area never seals flat to the chest. So when the patient inhales, it pulls the seal flat to the chest. However, if air tries to come out, it can actually push its way out through those pathways, thus ventilating outside the chest wall. The last item shown there is an occlusive dressing. It's a piece of petroleum gauze or Vaseline gauze that's fairly common on most trucks these days, and it's designed frequently to be used for a occlusive chest seal, and you can tape it over the wound, possibly on 2 or 3 sides. You may, if you tape it on 4 sides, you may have to burp it periodically. Now, one thing I want you to look at is the size of that gauze piece versus the size of the other 2 items listed there. The gauze is fairly small, and the gauze is impregnated with petroleum jelly or some similar consistency substance, and can frequently be very, very difficult to actually get an adequate seal with. If you look a little closer, you'll see there's this tinfoil wrapper there. That tinfoil wrapper can actually be used as an occlusive dressing. It's airtight in and of itself, much like the improvised picture was on the last page, which I believe was done with a wrapper from an IV fluid bag that we had used. You can use this, and again, if it provides an airtight dressing, we tape it down on 3 or 4 sides, as long as air can escape, and we can burp it to let air out of it, but it keeps any air from going into the chest cavity. Many times using the wrapper will be easier than using the small Vaseline dressing there. Also, we need to keep in the back of our mind, if you're dealing with a gunshot or something like that, if you've got one sucking chest wound, we need to do a rapid survey for an exit wound. One nice thing is the hyphen, which is the one in the middle there, actually comes as a 2-pack. 2 in the set because they are assumed to be using them in gunshot situations where you can actually seal your entrance and exit very quickly. And while that small Vaseline gauze may work well for your entrance wound, if you're dealing with a large caliber or high velocity projectile, that Vaseline gauze may not cover an exit wound adequately. And so again, keep in mind you've got that wrapper. You may have wrappers from other things you've used on the truck. IV fluid bags I've seen used several times. You can very quickly take the bag that you've used, the wrapper that it came in, cut the top and bottom off it, fold it open like a book, and it will cover a large area. Let's say this patient has 2 or 3 wounds. They've received multiple gunshot wounds from a 22 or 25 at close range, and they're all bubbling blood. Instead of trying to seal them individually, make one giant seal that covers multiple wounds. So again, keep in mind, yes, there are great seals out there. There are commercial seals The end goal is we need to allow the air that needs to escape and keep any air from moving in that direction. We want every bit of air that does make it into the thoracic cavity to come in by way of the airway itself, because that's the air that gets into the alveoli itself. That'll help maintain our respiratory levels and our tidal volume. Alrighty, now what happens if our pneumothorax develops a tension? We start to see a presentation including poor tidal volume. We see diminished breath sounds. We can't hear breath sounds on one side, or we barely hear them on one side. This will frequently be accompanied with hypotension or low blood pressure. JVD, jugular venous distension. Why? Well, it's hard to get blood back into the thoracic cavity once that pressure starts building up the tension, so now blood is backing up. Well, what feeds the superior vena cava? The jugular veins. So now, again, blood backs up there. We mentioned hyperresonance to percussion. If you think of the patient's skin being like the skin of a drum, it's stretched very tight, and now there's air behind it. So if you percuss on one side, it may be very different from percussing on the other side. We hear hyperresonance. Oh, it's tight as a drum. That lets you know there's an open void behind it with a great deal of air in there. We begin to see a tracheal shift. Now, tracheal shift is later in the presentation of this. Typically, by the time you're starting to see a tracheal shift, the patient has gone pretty well down this road. And we need to address it very, very quickly, or we're going to lose respiratory function altogether. So how are we going to address a tension pneumothorax? Well, we do what's called a needle thoracotomy, also known as a needle decompression. We place a large bore IV catheter, typically either a 14 or 16 gauge, into the chest cavity to allow any of this free air to escape. This converts the tension pneumothorax, or spontaneous pneumothorax, into an open pneumothorax. Now, this needle is typically placed through the second intercostal space along the midclavicular line, or in some cases, it's placed in the fifth intercostal space along the anterior axillary line. Now, regardless of where you place it or how your protocols dictate to place it, the goal is simple. We need to use the needle to pop that chest and allow that free air to escape, thus encouraging the lung to reinflate itself. This can be basically the pre-hospital equivalent of putting in a chest tube to allow the air or whatever else is taking up space in the chest cavity to drain. Now, one thing we've noticed over the last several years is typically we were always using about a 2 or a 2¼ inch needle. That was what was always pretty much standard, although many studies are coming out now suggesting using a longer needle, 3 to 3½ inches. I've got both of the needles pictured there, and I put a pair of shears in just to include for a size reference so you can see the depth of the needle. This is largely due to the fact that, we as Americans are becoming bigger and potentially thicker, and when trying to make sure we get far enough in to release the air, we don't want to go too short. We want to make sure that we actually get through the entire chest wall and actually into where we can ventilate the air from. Now, when we're going to place the needle in, it should have some type of a flutter valve on it. Now, we can put some type of chest seal over it. I know the Asherman works very well in this setting. A lot of times we'll use the Asherman chest seal. We can even remove the little piece of gauze that's on the interior of it and have that hole where the flutter valve is on the Asherman go directly over the needle, and there's our flutter valve. There's also several ways we can make improvised flutter valves. One way is to cut the fingertip off a standard EMS glove and use that as a flutter valve and put the needle through it prior to going through the actual patient's chest wall. Another option that I've seen for emergency flutter valves is actually using a condom. You can unwrap the condom itself, use it, put it on the patient's chest wall, and then pierce the needle right through the condom and the chest wall itself until you get your rush of air, and then unroll the condom to allow it to cover the valve itself. It looks something like this when it's done in practice, and again, as you can see there in the third picture across, as the patient would have any air coming out of there, that air would be allowed to vent, but if any air tried to suck in, the condom would keep that from going in. Again, I've seen it done multiple ways. I've seen multiple things. Depends on what equipment you have on your truck. Like I said, the Ashermans are great. They work wonderfully. And I've also seen a lot of people in an emergency use either a fingertip of a glove or have a condom in their kit. I know one thing I was told by an old trauma medic at one time. He said he liked using the condoms because they were small, easy to pack, sterile, and he could keep that with a 14 gauge needle and some betadine in a very small kit. And if he had to do a decompression of someone still inside a car during extrication, he had everything he needed in the pocket of his gear that he could do it right on scene without even getting into a compartment of the truck or his jump bag. Why? Well, again, attention pneumo needs to be addressed as soon as possible. He liked having the capacity to do it in the pocket of his bunker coat. Now, let's talk about some of the thoracic injuries that lead to heart damage. Most commonly, we'll see cardiac tamponade. Also, Commotio Cordis and Myocardial Contusion. Now, cardiac tamponade is a condition where excess blood or fluid accumulate in the pericardial sac between the actual heart wall itself and the sac. This leads to decreased cardiac output because this fluid keeps the heart from expanding adequately. The classic presentation you'll see is Beck's triad. This is made up of hypotension or dropping blood pressure, jugular venous distension from blood being unable to flow back into the heart and backing up into the jugular veins, as well as muffled heart sounds. Now, the muffled heart sounds may be a little bit difficult to hear in the field. However, if you're seeing hypotension and JVD along with an index of suspicion for a cardiac injury, this would be a possibility. We've also seen narrowing pulse pressures as a result of it. Commotio Cordis is a condition caused by blunt trauma to the chest during a critical portion of the heart's repolarization cycle. Now, while we may not know what part of the cycle got damaged, we do know that a patient suffers blunt trauma or contact sports, injury to the chest wall, and suddenly presents as either apneic and pulseless cardiac arrest or experiencing sudden new onset seizures would give us a high index of suspicion as what we're dealing with. Now, these patients should be managed based on their presentation. If we're dealing with seizures, we should treat the seizures. However, we should also be wary of cardiac arrhythmias and should include CPR and AED if the patient is pulseless. In this, what's happened is basically a pericardial thump, for those of you who have been around the block a while, has actually imparted enough energy into the patient's heart that it has knocked it out of rhythm. By knocking it out of rhythm, it's likely to be in ventricular fibrillation or something similar. We can also have myocardial contusion. Now, this mechanism of injury is very similar to Commotio Cordis. It typically doesn't result in immediate circulatory collapse. However, the injury may occur at the cellular level or cause damage to the vessels along the surface of the myocardium. The heart, as we know, is a muscle. So now this muscle can be irritated. It may present with ectopic activity, such as premature ventricular contractions, various reentry pathways, other dysrhythmias, and frequently they'll have pain complaint of sharp retrosternal chest pain. So they may have been hit by something, may have been, again, a line drive in a baseball game that goes back, hits the pitcher in the chest, and all of a sudden they're starting to have, sharp chest pain. These patients should definitely, any patient you suspect of a cardiac contusion or commotio should definitely be placed on the monitor. It's definitely an ALS management. Provide primary supportive care, manage the arrhythmias as needed, and support blood pressure. Hopefully we can do this and manage the patient to the hospital where they can recover from the contusion or whatever else has gone on. Lastly, we're going to get into traumatic asphyxia. Now, traumatic asphyxia typically results from a sudden traumatic compression of the chest that causes pressure to be translated backwards in the veins to the head, to the neck, to the kidneys. Your presentation on this will include widespread cyanosis or blood vessels breaking among the upper torso, the neck, the face. They may almost seem purple and bruised, even though they had no direct impact. Upper extremities, again above the compression level. What's happened is so much force has been applied to the chest, the thoracic cavity has actually forced blood to go backwards and traveled the wrong way in the veins. They may also have bleeding in the conjunctiva of the eye. Eyes may be bulging out. Some patients may actually have swelling of the lips, tongue, or up around the neck. Care for this is primarily supportive and definitely transport to a trauma center. In closing, although calls with significant thoracic trauma, Commotio Cordis, pneumo or hemothorax, flail chest, they can be fairly rare. We as providers need to aggressively identify them and treat them when we run across them. And given the fact that many of these will directly affect the patient's ability to breathe adequately, they should be addressed early in our care, as yes, they're rare, but they're also definitely immediately life-threatening. Hey there, I'd like to thank you all for stopping by, checking out our video. If you want more information about our company or any of the stuff we do, you can check out our website. If you need EMS continuing education hours, we do have our online education platform posted up there. Also, we have our email address if you have any questions. You can find us on YouTube, Facebook, Twitter, and Rumble. We maintain channels on all of those. Also, please like, share this out to your friends, subscribe, help support the channel, and we'll keep putting more videos out there for you. Oh well, enough about that. I know what I'm up for. Time for a cup of coffee. Y'all have a great day. Be safe out there. Bye.